Hello, my name is David Bishop, and today we're going to be talking about perioperative analgesia, particularly in the district hospital setting. And I'm aiming this to be quite a simple talk. We're just going to cover some of the basics around perioperative analgesia with a little bit of complexity when we get to the intraoperative phase. Now, why do we care about pain? The first reason is that it's sore, and I know that seems obvious. We'll all help the patient who's crying out or is in obvious agony, but we might miss the patient who appears to be coping with their pain, but is actually not coughing or breathing deeply because of that pain, and that should worry us. It will also stop them mobilizing, and we'll see complications such as atelectasis or the complications of immobility like hypostatic pneumonia or DVT. And so not only are we trying to relieve that patient's suffering, but we're also trying to prevent poor short-term outcomes. And those short-term outcomes incorporate those problems. It also might lead, if you've got a patient with ischemic heart disease, you might find that a patient in pain will be tachycardic or hypertensive, and then they'll be more at risk of a perioperative myocardial ischemia. So these are some of the reasons that we want to treat pain, not only for humanitarian reasons, but also for short-term benefits in terms of outcomes. Treating intraoperative pain correctly will make your anesthetic easier. And this is a concept which it took me a while to appreciate. I'm going to go through that just now. But if you treat pain effectively intraoperatively, you need less anesthetic gas, and then you actually run into less hemodynamic problems. It's an important sign, pain, so when you treat it correctly and then patients develop new pain, it might be pointing you towards pathology. So the assessment of pain on a regular basis is a very important sign. And finally, there are long-term outcomes which I suspect most of us are unaware of, especially at district hospital level, that may occur when the patient's been home for a few months that you may be unaware of. And the one that I'm particularly talking about are chronic pain syndromes. And this is really defined by persistent pain that doesn't have another cause or wasn't there before, and that is still there after at least 2 months after the surgery. And this table comes from Anesthesia and Analgesia, and it's just showing you what the incidence is after various surgeries. And you'll see some of those operations you'll do at district hospital level. Limb amputation, 30 to 80% of them have pain beyond 2 months. You might do a hysterectomy. Cesarean delivery, 10% of patients still have pain after 2 months, and many of them go on to develop chronic pain syndromes. Breast surgery, groin hernia surgery, and then the higher numbers that we know are associated with things like thoracotomy, which hopefully you won't be doing. But common surgeries are associated with chronic pain syndromes, and this incidence is modifiable based on how we treat them. By sorting out the short-term pain, you actually also prevent or minimize the long-term poor outcomes. But unfortunately, the reverse is true. If you don't treat pain well, you increase the incidence of chronic pain syndromes. Now, we used to talk about preemptive analgesia, and we've moved on to a concept called preventive analgesia. Preemptive analgesia, the concept was that we would give pain medication or put in a block before the surgical incision so that the patient never felt that primary surgical incision. And the idea was that would prevent post-operative chronic pain syndromes. And what we found is that if you did that, it's all well and good, but then if you failed to treat pain during surgery and after surgery, you still got those chronic pain syndromes. So we've now moved on to a concept of preventive analgesia. Essentially, we still give the preemptive analgesia, but the focus is also on the intraoperative period and the postoperative period. And basically, it boils down to you must minimize pain in every way at every step. And you minimize it both in non-pharmacological ways and in pharmacological ways. Now, non-pharmacological pain management approaches, they always produce diagrams that look like this, and they're behavioral approaches and movement-based approaches and mind-body interventions. And I don't realistically think that you're going to be able to do yoga with your patients in the ward, but there are things that you can do which will minimize pain. You can plan things like dressing changes for just after the analgesia. In cesarean section, the practice that I've noticed is one that we'll never be able to eliminate, is that all patients seem to have to have a shower at 5 o'clock the morning following the cesarean section, which is one of the most painful things you can do to a woman. So plan things like that. If they have to get clean, either a bath or a shower, give them the analgesia just before you do that. And then other things like family support, distraction. Can they watch the football game? Can they have music? Can you get your allied health team in? Physiotherapists and occupational therapists are brilliant at assisting these patients. So don't forget those other modalities that might be available to you in that setting. Now, there are 4 distinct phases that I want to talk about around perioperative analgesia: pre-op, intra-op, post-op, and the post-discharge phase. And you can imagine that this patient is going to have some sort of pain over that time course, and I've just drawn this curve in very roughly to look like that. And each phase is important. The patients can have pain preoperatively, they have the most pain intraoperatively, and in the postoperative phase we hope that all starts to settle. And obviously the time periods are different. That intraoperative phase is measured in minutes and hours, and the postoperative phase in hours and days. And each phase has a different approach. So what is important is that you're assessing pain at each phase, and you're regularly thinking, is this patient in pain, and how do I adapt my strategy? The strategy is adjusted to the phase that you're in, and there are different considerations in each phase. And throughout, I'm going to be talking about multimodal approaches. Always look to get as many ways to treat pain in as you can, and then if you can, bring in those non-pharmacological methods. So in the pre-op phase, I'm not going to spend a lot of time on this, but essentially, just ask yourself the question: when patients arrive in theatre already in pain, has anybody made any attempt to treat that pain? We've got this teaching that patients who have peritonitis mustn't get treated because then you can't assess if there's peritonitis. And that's all well and good in a casualty or an emergency department. But once the decision has been made that the patient is peritonitic and needs an operation, give pain relief. Surgeons don't or shouldn't come in and re-examine patients on an operating table. The patient's already been seen and the decision has been made. So once I know the patient's going to have their abdomen open, I treat pain aggressively before we start, because that patient's got a lot of painful things that are going to happen. They've got to move from the stretcher to the operating table, and you can see the ones that are sore. Remember that it's not only morphine that you can give oral paracetamol if you don't have IV or rectal paracetamol available. You can give that quite early in some patients that are able to take orally. And then I often give my opioid while the patient is still on the stretcher. Once I know what their blood pressures are, I give them their morphine dose before I've done anything else, because morphine can take 20 minutes before it starts working, up to 40 minutes. So why not get it in? So think, can I treat the pain before I start the anesthetic? Why not? Now, the intraoperative phase, it's absolutely critical to get pain control correct. And young anaesthetists or beginner anaesthetists get this wrong. I certainly did. We go with lots of gas because we're worried about awareness. So we give lots of gas, and then we find because we've given lots of gas, the blood pressure is very borderline, and then we're scared to give a drug like morphine because we think it'll drop the blood pressure more. So because we're worried about awareness, we're unable to treat pain effectively, and that paradoxically makes it more likely that there will be awareness. So, my very first solo anesthetic, I had done 4 days of supervised anesthesia, and I was doing a solo call at the hospital where I worked, and the man was a 26-year-old man for an exploratory laparotomy for a stab abdomen, and I did a general anesthetic with a rapid sequence induction, and I put an endotracheal tube in. I used thiopentin and sucks because that's what we had, and I started my isoflurane at 1.2. In tidal 1.2. Remember, the MAC of isoflurane is about 1.15, but I was calling it 1.2. And I actually wanted to go higher because my reading had said that 50% of patients would move if I gave that much. So I was trying to go as high as possible. And then the blood pressure was borderline. And because of the blood pressure being borderline, I gave a total of 3 milligrams of morphine for the whole operation. And he got through the operation all right, and in recovery he was fine. I was delighted that he had come through the operation, but he was in absolute agony. And a more senior anaesthetist who was working somewhere else that night walked into the room and gave him 15 milligrams of morphine IV as a stat dose, and I was absolutely horrified. And essentially, the definition of MAC is what messed me around. And the definition, if you remember it, is the minimum alveolar concentration required to prevent movement in response to a surgical stimulus in 50% of patients. And a surgical stimulus is defined as a knife to skin, so people sometimes call it MAC the knife. So I was under the impression that I had to give at least 1.2 to prevent movement. So that's why I did it. But what I had failed to appreciate is that this is in a patient who hasn't had analgesia. And if you give analgesia, you need much less gas. So the key to an anesthetic is taking care of the stimulus, and then you require less sedation. Remember that anesthesia is a balance between sedation and stimulus. And if you give enough attention to eliminating the stimulus, if the patient doesn't feel any pain at all, you only need the gas required to keep the patient asleep to an endotracheal tube. And if you think about the gases that we use, isoflurane or sevoflurane, the MAC of isoflurane, I've said it's 1.2, it's actually 1.15, and sevoflurane is 2. So if you wanted to keep 50% of patients from moving, you would have to give that amount of gas if you weren't using any analgesia. But remember that there are other kinds of MAC. There's MAC awake, which only needs about 0.3 to 0.5 of a MAC. 1 MAC, that's your surgical stimulus, 50% of patients. 1.3 MAC, now 95% of patients won't move. So for isoflurane, you're giving just over 1.5 in tidal to prevent 95% of people. And if you do that, there's going to be no blood pressure when the patient's asleep. So you have to take care of stimulation, and then you don't need this gas. And most of my patients, when I'm giving them good analgesia, are running on an end-tidal isoflurane of about 0.8. So you don't need these massive doses of gas if you took care of pain intraoperatively. This is just a graph that shows that. So for the different types of MAC, as you give more opioid on the x-axis, you need less gas on the y-axis. And it makes sense. If you give a patient 100 mics of fentanyl or 500 mics of fentanyl, they will need much less gas to keep them from moving. So how do you do that? So one of the ways is you give morphine. You give the morphine, and that reduces pain over time. The problem with morphine is it's got a low ceiling. And by that, what I mean is it's good at post-operative pain. It takes care of moderate pain, but severe pain, like you would feel if someone's operating, morphine is not very good at taking away all the pain. And it also takes time to work. So if you add in that pain curve that I drew earlier, morphine is actually insufficient to cover the peak of that curve while someone's operating. And if you want to then take care of that pain in an appropriate way, most anesthetists, specialist anesthetists, will use a synthetic opiate like fentanyl or remifentanil or sufentanil. Now in the district hospitals in South Africa, you've mainly only got fentanyl, so you would want to be giving fentanyl to overcome this high intensity pain. The problem with that is that many of you are unfamiliar with that, and also if you give too much fentanyl, patients can struggle to breathe. So the other way to do this is to use as much of the local anesthesia that you can and multimodal approaches. So don't just give morphine, give as many things as possible to try and reduce intraoperative pain. So you see diagrams like this, which are talking about multimodal analgesia. Remember, you've got systemic options, so opioids, anti-inflammatories if there's no contraindication, paracetamol, NMDA antagonists like ketamine, and then you've also got regional anesthesia. And you might be able to do these blocks, but at the very least you've got local anesthetics and wound infiltration. So use these things when you can to minimize intraoperative pain. So when I'm doing anesthesia in the district setting, I look to bring in local anesthesia or a block if I can, as a matter of course. I then look for multimodal options. So if I've got IV paracetamol, great. If I don't, I look for whether I can get it in orally or as a suppository. I always try and give an anti-inflammatory if there's no contraindication. And anti-inflammatories are useful because most of surgical pain is inflammatory in nature. So whenever there's no contraindication, they're getting one from me. Orally, intravenously, they're getting it post-op if I can get it in. And I'll talk to that just now. Opioids are almost invariably used. You can use morphine, give a proper dose, 0.1 milligrams per kilogram. But what I often do is I give them morphine as they come in the room, and then I'll use my fentanyl just to cover the surgical incision. And I'll give them 1 to 2 mics per kilogram, so 50 to 100 mics of fentanyl as they do the incision, and that covers the 20 to 30 minutes of the operation. And then consider using ketamine. And ketamine works through its NMDA antagonism. I give a 1/4 to 1/2 milligram per kilogram, so that low dose ketamine, if you give it more than 20 minutes before the patient wakes up, it won't compromise the wake-up time, and then it also may reduce the incidence of chronic pain syndromes. So ketamine is something that you can build into your anesthetic as part of your multimodal approach. Remember that the post-operative phase starts in recovery, so when your patient wakes up and is in recovery, treat the pain and get the pain under control before sending to the ward. Because if you just write up pain medication for the ward, often there'll be delays when you get there, and that patient will lie in pain for hours, and it's very difficult to get on top of it. So titrate some morphine in. Give the other modalities if you've got them. And remember also to treat vomiting and nausea, because with the morphine is going to come nauseous often. So if you've got anti-nauseas, whether you've got an ondansetron or a metoclopramide, preoperatively you can consider dexamethasone. Look to treat nausea and vomiting prophylactically in certain patients. Remember that part of the ERAS, or enhanced recovery after surgery, is effective pain control, and they stress that you need multimodal analgesia. You must try and spare the opioid by giving the other modalities, because opioids are associated with gut dysfunction, nausea and vomiting, and obviously opioid addiction, which is a rising problem in the first world. So find other ways to reduce the need for opioid, but if you need it, you must give it. And that'll get patients mobilized earlier, it'll get them home earlier. So in the ward, assess pain every time you see patients. Try to get into the habit. Use multimodal approaches, so all my patients are getting an anti-inflammatory and paracetamol, and then I add the opioid as I need it. The anti-inflammatory, unless they're contraindications, they should be getting for at least a few days. And think about your script strategies, how you write these things up. So what I do, if I've got a seizure, I'll write up 2 days of an anti-inflammatory, and then I'll be forced to review the script. And then I'll be able to think, has this patient complicated? If you write a 3-day script, that's usually when you're discharging the patient. And if there's someone that is not fit for discharge, you will then be forced to review your script. And if that patient is septic, perhaps the anti-inflammatory is not a good idea. That patient is developing renal impairment, not for an anti-inflammatory. So just in finishing, I'm very briefly going to take you through what I'd be doing for these conditions. Someone comes in with an appendicitis, I'm going to give them an opioid pre-op, either morphine or fentanyl. If the abdomen looks good once they're inside, I will give an intra-op anti-inflammatory, or in recovery, they'll get paracetamol and low-dose ketamine, and they'll get a morphine 0.1 milligram per kilogram. I'll use local anesthetic into the wound. In recovery, I'll titrate morphine in until they're comfortable. And in the ward post-op, they'll get 3 to 5 days of paracetamol, 2 to 3 days of an anti-inflammatory, followed by review. And morphine, I'd prescribe for at least 2 days, and then I would transition them onto something like tramadol, or if it's been a small incision, maybe they don't need an opioid. And I would treat a rising amount of pain on my pain assessments as a potential problem. Perhaps this patient is developing sepsis or a complication. For an ectopic pregnancy, I would do exactly the same, except that if the patient came in a cardiovascular unstable situation, low blood pressures, I would probably not use morphine. I would use either ketamine or boluses of fentanyl, and I would not give an anti-inflammatory to a patient that was in hemorrhagic shock. And the rest would be identical. For a cesarean section, and I'm talking about the general anesthetic cesarean section, again, it's exactly the same with some modifications. I would hold the opioid back until the baby was out. I would want to give an anti-inflammatory in all patients, except that I would hold it back where there are contraindications like hemorrhagic shock or somebody potentially with preeclampsia and renal disease. But in everyone else, I'll be trying to give exactly the same cocktail of drugs. And finally, for an open long bone fracture or a tibial fracture, again, I would use the same approach to analgesia, but I probably wouldn't put local into the wound. I might consider a nerve block if I had the skills and an ultrasound. And the anti-inflammatories, while controversial, orthopedic surgeons often don't like us to give anti-inflammatories because they're worried about bone healing. In the acute setting, they get an anti-inflammatory from me. I just avoid long-term anti-inflammatory therapy in the post-op period. And finally, the post-discharge phase. And just remember that pain control extends beyond discharge. And we must send them home with analgesics if they require them. Chronic pain syndromes are very difficult to deal with at district level because they require multidisciplinary approaches, often pharmacological interventions that are unavailable, and support on multiple levels. And the best way to manage them is to prevent them. And that's best done by trying to avoid pain wherever possible throughout surgery in the post-operative period. Thanks very much.